Yeah, so as we get started, we hope to spend the next about 55 minutes now discussing the impact of COVID-19 on various aspects of cardiovascular imaging. We've divided this time into two halves. In the first half, we look forward to discussing recent case reports that have been published in JACC Cardiovascular Imaging, asking the question, is there an association between the COVID-19 vaccine and myocarditis? And what are the implications for cardiovascular imagers? In the second half of this discussion, we'll be discussing the impact of COVID-19 on cardiovascular testing, both in the United States and around the world. And we'll be joined in these discussions by the primary investigators and study authors of these case series and of the INCAP study. I'm very delighted to again introduce Juan Lopez Matei, my co-moderator at MD Anderson Cancer Center, who serves as the social media editor at JACC Cardio-Oncology. And I'm Andrew Choi. I'm a cardiologist at George Washington University and serve as the social media editor at JACC Cardiovascular Imaging. We're joined today by Dr. John Dickey, who is assistant professor of medicine at the University of Massachusetts Medical Center and has published with colleagues a publication entitled "A Series of Patients with Myocarditis Following SARS-CoV-2 Vaccination with mRNA 1279 and BNT162b2, or more colloquially known as Moderna or Pfizer vaccines." We'll be joined shortly by Dr. Mario Gosel, who's an interventional cardiologist at the Minneapolis Heart Institute, who has published a concurrent case series entitled "Possible Association Between COVID-19 Vaccine and Myocarditis, Clinical and CMR Findings." And we're also honored to be joined by Dr. Michael Salerno, who's an associate professor of medicine, radiology, and biomedical engineering at the University of Virginia and serves as associate editor at JACC Cardiovascular Imaging. So welcome to all, and I invite Dr. Dickey to present to us the findings from your case series. So Dr. Dickey.
Thank you so much for having me. It's a real honor to be here with everybody. This series of patients that we published about all presented to us about the last 3 months ago as the vaccination efforts ramped up in Massachusetts. We had 6 patients in total, all of which were men, ranging in age from 17 was the youngest and 37 was the oldest. And all of whom presented with symptoms that were pretty, I would say, classic for myocarditis, chest pain, pleuritic chest pain, positional, that started within 2 to 4 days of their second vaccination with either the Pfizer vaccine or the Moderna vaccine. All of them had elevation in the cardiac troponin I on presentation. All of them had some degree of ST segment deviation, some of which presented with ST segment elevation requiring activation of our cardiac cath lab. Patients were taken for emergent angiography. None of them had any evidence of coronary artery disease. Only 2 of them had fever, which was an interesting fact. They all had elevated inflammatory markers. CRP and ESR were both elevated. And 5 of the 6 of them had some abnormality in left ventricular systolic function, all very mild, EFs generally above 45%. They all underwent cardiac MRI imaging demonstrating evidence of edema on T sequences and late gadolinium enhancement in corresponding distributions, meeting Lake-Louise criteria for acute myocarditis. They all recovered very rapidly and were discharged home, and as of yet have not had any long-term complications so far.
Very interesting, case series, and I have a question for you. How if you know this, how fast a cardiac MRI was done, or how early you guys will consider doing a cardiac MRI with such clinical presentation?
That's a good question. I think for the for all of these patients, they had actually, I think one of them had an MRI after they were discharged, but at least the first couple that we saw, they were done pretty much within the first, I would say, 48 to 72 hours after their presentation, as we were really trying to nail down what their diagnosis really was. We weren't considering up front that this really had anything to do with their vaccination status, and we wanted to confirm, was this myocarditis? Was this some other entity that we needed to consider? So they were done very rapidly.
Because the thing is that in reality there's many centers that they don't do endomyocardial biopsy for X, Y, and Z, sometimes lack of expertise and all this. But it's so important to consider upfront, especially now that we know that there's a temporal association. So we have to definitely consider this, because I think in all your cases got MRI, and this MRI was what confirmed you the diagnosis. Is that correct?
That's correct. Yeah, absolutely. MRI was really the deciding factor in making these diagnoses for these patients. I think without them, you would have had a kind of presumptive diagnosis of myocarditis after excluding other causes of similar symptoms and presentation. But the MRI was really kind of critical.
Let's move to Dr. Gosel, who has joined the line, an interventional cardiologist in Minneapolis Heart Institute with expertise in structural heart disease. Welcome, Dr. Gosel.
Yeah, thank you. And sorry for being late.
Yes, we're delighted to have you. We'd like to invite you to present just your case series and the observations that you had made in this series entitled Possible Association Between COVID-19 Vaccine and Myocarditis, Clinical and CMR Findings, currently online and press at JACC Cardiovascular Imaging.
Yeah, thank you. And I just listened in, I think the last couple of minutes of the prior presentation. So I think we all had interestingly similar experiences around the same time, which I think makes a lot of sense as the younger population got vaccinated. But I was on the hospital service at that time, and I had very similar findings. I think we collected about 12 patients now. They are not all in the paper, but due to IRB, of course, needs, you couldn't just publish everybody first. But we had similar experiences. So patients we had 2 patients who showed up after a first vaccination and 2 after a second dose of vaccination. And the interesting thing in our, I think, paper is we have a little chart in there where our resident, Dr. Shaw, who did an amazing job in putting this all together, really highlighted the temporal relationship of these 4 patients at least. And interestingly, 2 of them actually had a documented COVID-19 infection prior to getting vaccinated, and sometimes even months before that, without myocarditis at that time. And 2 had, in my eyes at least, still high-risk jobs. Again, younger folks who were maybe waiters, for example, around the COVID pandemic, and they wore masks, as they said, but nevertheless they were exposed in my eyes. So I think in conclusion, I mean, we had also cases after first or second doses of vaccinations. We had, compared to the other cases, sometimes 2, I think we have 3 or 4 days afterwards, sometimes 25 days afterwards, presentations. Our MRIs were done within 24, 48 hours of that presentation, and just very similar findings of an acute myocarditis that was very much temporarily related to the vaccination and not otherwise explained. Patients are doing so far good. They are coming back for a follow-up very soon, and we wanted to really have thorough follow-up and see how they are doing. But for me, I think I want to post this out, is what people think about the potential of maybe a prior infection playing some sort of role in this whole observation.
Yeah, I agree. I think there are a lot of kind of interesting mechanistic questions to ask, and I point our listeners to the online publication. And the first figure goes through the timeline of each of the individual cases as well as the relationship to the vaccine. Both for Dr. Dickey and then maybe for Dr. Gosell first, can you take us into the imaging findings and specifically the LGE patterns that you've observed and how they compare to other myocarditis cases? And you also uniquely have the T2 mapping and also how those values compare to other myocarditis cases.
Yeah, I'm not sure if my co-author, Dr. Cavalcante, has joined here, but as you pointed out, I'm a plumber more than an imager. So, I would rely based on our paper on what he has written there. I'm not really, I don't think I will be the expert in explaining to you the MRI images. We were the ones who were collecting the cases with Dr. Schaber. Definitely Dr. Cavalcanti, I'm not sure if he's here or not, was the imager in helping us there. What I learned from him is that there, of course, criteria for acute myocarditis, and also in writing the paper and also the later review process was interesting to me, because obviously there were a lot of questions about, how can we really ascertain that there's an acute myocarditis or not? Was there maybe another relationship? Is there a coincidence? We used the official criteria that were published and tried to get closer to it. But I think if you have specific questions about MRI, maybe there's another expert on the line who could explain that better.
Yeah, maybe we can ask Dr. Mike Salerno from the JACC Imaging Editorial Board to weigh in on his thoughts about how parametric imaging uniquely added to this case series.
Yeah, I think Dr. Salerno has had maybe some difficulties joining on the call, so we'll look to his comments here shortly. I think what's striking for just individuals that are listening is both the dense nature of the LGE in the first case series, and also these skip patterns of edema and LGE that are maybe more atypical in a myocarditis case. Can you speak perhaps to what your observations, Dr. Dickey, in your case series?
Yeah, I mean, I think what you've kind of mentioned is pretty on the money. I mean, one of our cases had this very kind of classic distribution of myocarditis kind of in the infralateral wall, but most of the others had this patchy skip nature to it, not in any one vascular territory. I mean, the more classic findings were that they were all kind of epicardial or mid-myocardial in their involvement, not a kind of transmural pattern of LGE or edema that you would expect in someone who had a thrombotic occlusion of an epicardial coronary vessel. So I think there were some features that were, typical for, myocarditis as it is described in literature, and other things that were a little bit less typical that we saw. I think it was just an overall very interesting pattern of findings.
Yeah, I do believe that the parametric imaging helps in having other criteria at hand, and also whenever you can actually quantify the edema, and if you have a long case series, you can certainly look into that and see if this is related to prognosis in a potential study. But I think it's very interesting because at least the paper from Dr. Goss, I think highlights the importance of parametric imaging, and I look forward to that. But the other case series with LG and that pattern of the infralateral wall, tends to be very repetitive, although the skip pattern also is there in some of these cases. So I think it's important to start recognizing the phenotype, and I think as we get more manuscripts in, we're going to definitely start seeing more consistent patterns.
Can you also describe, so it's important that in both of these case series, the Lake Louise criteria were used. I think let me just point out to our listeners that, that not only was there these patterns of mid-myocardial enhancement, but the presence of myocardial edema, which is a main criteria of the Lake Louise, with the, as identified by either the T2 weighted images in the UMass series or the T2 maps that are here in the Minneapolis case series, in addition to patterns of pericarditis and LV dysfunction that support the diagnosis.
So Andrew, this is Leslie Shaw. Is it okay if I chime in for a
Yes,
moment?
please, please.
Okay, great. I've been wondering. So I just wondered, can we all highlight more globally, the CDC panel on this, what their take was on that, just to put all of this in perspective? They recently released a statement, mostly focused on the denominator, I guess that was right. They didn't really focus on the imaging findings, but.
Yep. Let's ask our speakers. How do we put these findings now in a more global context? Both in, what do we think, is the actual, the denominator or the incidence of these cases?
Yeah, if I can start. I mean, when we got our paper published shortly after, I think multiple comments were made, and I think very shortly after the CDC presented the data, and I think obviously it is very low, the incidence of that, as far as we know. I think they were, correct me if I'm wrong, but I think it's like 300 or 400 cases reported. I'm not sure if they were all thoroughly done as our case series, but the incidence is really low. I think it's nevertheless, and that was pointed out, I think, by Dr. Shaw and others too, I think it's just important to collect these cases and simply maybe potentially get to a pattern of who and why some patients have reacted that way. And I'm not an ID person. I'm unfortunately really more on the structural side of things, but I really wonder if potentially certain variants play a role, because I still think that most of my patients, I think, had a previous exposure. I'm almost convinced about that. I don't think it's just the vaccination, but it's just a theory. And I think it's nevertheless very low, but the cases that we have seen have certainly significant symptoms. And I also know about a few cases that actually ended up in the intensive care unit because of myocarditis. So I think it's something to really observe and figure out who might be at higher risk. But due to the incidence, I think it's going to be, very thorough and very difficult research. But I think it's important. Nevertheless, we should not discourage people not getting vaccinated. I think that was pointed out multiple times, and I totally agree with that. We would be at a very bad spot, everywhere if we wouldn't get vaccinated. We just have to, as physicians and as a global community, have to simply observe cases and figure out where this relationship might be coming from.
You alluded to a prior exposure. Do you think it's a repetitive exposure in an essential worker, as you alluded to? Is that your hypothesis here? Because they're just cases, so
yeah.
It's helpful just to be a little bit more exploratory in your thoughts.
Yeah,
okay with that.
Absolutely. So I think we had one worker who said that he would be a seasonal waiter and could have had multiple exposures during the pandemic. I'm pretty certain. The other three that we published, at least, had what it appears to be just one exposure, and after that were really careful not having further exposures. So that's what we know. Excuse me, one person had, the other person we don't know. But one person had an exposure that was pretty sure, but then very careful afterwards. So I only have one person really where I can say that prior to the vaccination had multiple potential exposures, but was definitely asymptomatic at that time, didn't know that he had an infection, for example. But it was just, I think it's just a theory, obviously, but we had two who were exposed, two who were just, young and trying to do as much as they could during the pandemic. And one of them definitely, due to his work, also exposed multiple times a week. So yeah, just a theory, you're right.
Interesting.
Let's address also Dr. Shaw's question. So, I want to point our listeners again to the CDC's guidance. And so just 2 days ago, they had updated based on their vaccine reporting system, about 40 cases per million doses of the second dose of the mRNA vaccine and 2.4 per million second doses to men over the age of 30. And among women, it was about 4 per million as well. So the incidences remain very low. And as a reminder that these cases continue to be collected by the CDC. Both for Dr. Dickey and Dr. Gosel, what is your advice on, how should a clinician, and again, these are only, we highlight, these are temporal associations only, even as we speculate around the potential mechanisms, how should a clinician approach a potential case, and how did you both approach potential cases?
I can speak to the cases that we saw. I approached them. The initial cases, I approached them as some sort of undifferentiated acute coronary syndrome, but now in retrospect, that was probably a bit overkill. But I think now, kind of knowing that there may be this temporal association in how these patients present, I would, approach them as I would any other case of myocarditis. You have to be aware that the inflammation is going on, that some patients who have myocarditis have much more serious types of myocarditis that aren't necessarily related to prior viral infections or even vaccination. And you have to monitor them closely. You have to watch them for arrhythmia, which is a serious cause of morbidity, I think, in this kind of global group, not necessarily just post-vaccine cases. But that it appears to be, at least in these small numbers that we have thus far, a relatively benign course that seems to be recovering on its own with conservative management.
Yeah, following those comments, I think it's just a risk versus benefit ratio. I mean, the risk, is still very low in the sense of numbers of, double digits in millions, versus having complications with COVID and having more dead, and we don't want that, right? But I think it's very important to of course consider all of this, and most of these cases seem to be so far with a benign clinical course. And I wish Dr. Salerno could weigh in, but he's having some technical difficulties, so he's apologizing, but he's following the discussion. But I think, yeah, I completely agree that we have to be vigilant, but this should not deter anyone to get vaccinated.
Absolutely, you're right. Yes, and I agree. We had the same experience. I think the very young patient, of course, I think it's absolutely overkill to think about an acute coronary syndrome. The others, very hard. They come in. We had no clue that these cases were happening elsewhere at that time. And, they're in the 20s and 30s, and they really present as if they had acute coronary syndrome. And yeah, we probably also did overkill, but I agree with the previous speaker. Now we probably approach them a little different. Is it really easy in this circumstance here in the United States to simply say, I think this is vaccination related, so let's just do X, Y, and Z? I think we often do a little overkill to simply be sure that nothing else is wrong. But yeah, in the beginning, we were thinking differently, that's for sure.
Absolutely. And, I think that, part of this, when we started early, I noticed, we noticed, because we have a group in WhatsApp, and we noticed that people were, reporting these cases very early, and some group of us unofficially start discussing about these cases and kind of sharing our experiences. And there was a lot of things happening right now, that this group that we put together of people that now they're organizing and putting together some of these cases. And I think it's important us as physicians to communicate and know what's happening in other places, especially in situations like this in the pandemic. I mean, all these social media platforms and very good close communication is so important, because sometimes a lot of good things can come from the sense of innovating approaches and monitoring and surveillance of certain complications.
Dr. Dickey, what is your recommendations or advice based on your clinical experience for these patients?
My recommendation is, or has been for them, that much in the same way I would recommend anyone who has an idiopathic or viral myocarditis that they restrict their physical activity for a period of 3 to 6 months. I mean, I think that's especially important in what appears to be a young and predominantly male population. These are people who are physically active, either in their work or in the cases of some of our cases, they were high school athletes or college athletes. So I mean, it's that's an important one to stress. And to then, after they've had that period of activity restriction and potentially serial imaging to document recovery of their left ventricular function or the resolution of their edema, to kind of get back into an exercise program gradually and not push it all at once. We prescribed all of these patients beta blockers up front, perhaps more out of precaution than anything else, but as I said, it seems to be treating them pretty well.
Any other questions or comments from our speakers panel? Dr. Shah on the line, Dr. Salerno just had some technical difficulties, but I know is following or trying to follow along today.
I would just like a quick comment is just to say thank you so much for submitting these very interesting cases to JACC Imaging. I think COVID, all rules and all bets are off with regards to, how it's going to impact our patients. And I think you all were awesome to spot this early on, and we thank you for submitting it to JACC Imaging. And we encourage, even greater phenotyping of these folks. Don't you think, Andrew? And even follow-up imaging, resolution of any kind of left ventricular dysfunction, et cetera, will be fascinating to watch.
Absolutely.
Definitely.
Totally agree.
Yes,
all right,
absolutely.
and we point everybody, all of our listeners, again, to CDC guidance, and that continues to overwhelmingly recommend vaccination for all individuals over the age of 12 years old. Thank you, Dr. Grossello. Thank you, Dr. Dickey, for your insights, for these important case observations, and for triggering, as noted in the cover of the JACC articles, just new science and new observations that will help us to really understand what is happening in these cases. So thank you so much for your time today.
Thank you for inviting us. Thank you.
All right.
Thanks for having me.
And you're welcome to stay and participate in the second half. And so as the second half of this discussion, we're honored to have a group of investigators from the important INCAPS COVID-19 study, looking at the impact of COVID-19 on cardiovascular testing in the United States versus the rest of the world. We're joined first by Dr. Cole Hirschfield, who is a superstar in cardiovascular medicine at the Weill Cornell Medical Center and the lead author of this paper. Dr. Michelle Williams, also a superstar in cardiovascular medicine, a senior clinical lecturer at the University of Edinburgh in the United Kingdom. Dr. Andrew Einstein, who is the senior author on this paper, an associate professor of medicine and director of nuclear cardiology, CCT, and CMR at Columbia University Medical Center. And Dr. Leslie Shaw, who needs no introduction, who is the executive editor at JACC Cardiovascular Imaging, also serves as an author on this paper, and is also importantly a professor of medicine, obstetrics and gynecology, and as well as population health, and the director of the Blavatnik Family Women's Heart Health Research Institute at Mount Sinai in New York. And so welcome to all of the participants on the call today.
Welcome.
Thank you.
Thanks for having us here.
Thanks.
All right, we'd like to invite Dr. Hirschfield to present the findings of this paper, Impact on Cardiovascular Testing in the United States versus the rest of the world, currently online in press at JACC Cardiovascular Imaging.
Thank you so much, and thank you for the introduction. It's a pleasure to be here and very exciting to be presenting our work. Since we're running a little bit late, on time, I'll give a very brief overview, as I think the discussion around the paper and the sort of implications is probably more interesting to the audience. But the study overall was coordinated by the International Atomic Energy Agency out of Vienna, with all of the people who Dr. Choi just mentioned. It's essentially what INCAP stands for is the IAEA, which is what I just mentioned, non-invasive cardiology protocol study of COVID-19. And the goal was really to characterize the impact of COVID-19 on cardiovascular procedure volumes during the early phase of the COVID-19 pandemic, which the data we have was from March and April of last year. And the worldwide study was actually published in January in JACC, and this was sort of a follow-up study looking specifically at the U.S. compared to the rest of the world, and really more so at the U.S. and the U.S. regions. And so we had almost 1,000 institutions from 108 countries around the world. And in the U.S., we had data from over 40 states spanning all modalities of cardiac imaging. And we used March 2019 data as sort of our baseline. That was what we had from these facilities, and then compared that to March and April of 2020. This paper focused more so on the April 2020, which was really the peak of the early pandemic, at least in the Northeast. And what we saw was pretty astounding, that procedure volumes in the US declined about 68% year over year. And compare that to about 63% in non-US facilities, but that was not a significant difference. So overall, similar declines around the world, which was pretty striking, not unexpected, but still a large number. And looking at specific procedures, we saw significantly greater reduction in invasive coronary angiography in the US, about 69% compared to 53% in non-US. And then the U.S. saw, I think, a rapid rise in COVID-19 during March and April, which we thought could have potentially accounted for this difference. And I think, interestingly, a significantly more U.S. facilities reported using things like telehealth, patient screening measures like temperature checks, symptom screening, COVID-19 testing, compared to non-U.S. facilities. And when we're looking just at the U.S. regional data, so forgetting the rest of the world, and just comparing our U.S. centers, we saw that the greatest declines were in the Northeast and the Midwest in April of 2020, about 75% reduction in cardiovascular procedure volumes compared to the South and Western states, which were only about 40 to 50% decline in procedure volumes. These are just all procedures lumped together. And there appeared to be a trend in the U.S. And non-U.S. sites to avoid aerosol-generating procedures more so than non-aerosol-generating procedures. So, for example, procedures like stress EKGs, stress echoes, which are usually completed with an exercise component, had declined by 81 and 85%, respectively. And compare that to something like stress PET, for instance, which can be done with pharmacological stress. Procedure volumes declined by only about 50% in the US. And we looked at predictors specifically, given this significant difference between the Northwest and Midwest in the South and West in terms of procedure volume declines, like what predictors might have been accounting for these differences. And one of the strongest predictors, not surprisingly, was the prevalence of COVID-19 in those regions, using the data that from Hopkins that was available at the time. Also, predictors included urban centers compared to more rural centers had greater declines, as well as outpatient centers compared to inpatient centers saw greater declines. And so overall, I think the big concern, and sort of from an epidemiological standpoint, is what is the impact of this? We did not track outcomes, or we don't have a specific patient outcome measure in the study to see whether this is significant in terms of the impact on cardiovascular disease. But I think what everyone suspects is that, that it sort of has to be. During the pandemic, we were all wondering, where are the patients? I remember some of the co-fellows at the time I was a resident at Columbia, and they had said, our STEMI page hasn't gone off in 4 weeks. Where are the patients? Where are the STEMIs? And so it's an interesting sort of thought experiment, although I don't know whether or not the data exists yet. I know there's some talk about it. But the editorial actually, interesting aside to this paper, which was written by two cardiologists out of St. Luke's Mid-America Heart Institute. I don't know whether they're on this call or not, but looked at follow-up data, not from patient outcomes, but from an imaging perspective, and showed a very swift rise back to near normal procedure volumes over the summer, and then those had sort of steady since then in the data that they sort of commented on in the editorial to this paper. So it's interesting. We're working on another rendition, which I think the team will talk a little bit about now, INCAP's COVID-2, which will be a follow-up to this study, which will be really interesting to see the results.
This is such an important work. Thank you. I just had a quick question for you, Cole. What do you think, aside from, because certainly we can measure what the different sites report, right? But there's a situation where either was the institution that was not doing the procedures, or also the patients were not showing up. So the question is kind of a bit more complex, but at the same time, I think that there were certain places where there were like very aggressive shutdowns, and sometimes it needed to be done. But now, knowing the masks, how good the mask works, do you think that your findings will be different if we were like using like more with better policies and masking from in the starts of the pandemic?
Do you mean whether the findings in terms of procedure volumes will be different?
Right.
Yeah, I think so. I mean, there's already data that exists showing, almost a return to normal in terms of procedure volumes. And as I think one of the, I think someone had mentioned on this call, or maybe I'm getting confused, but that, a lot of labs have really shown that procedure volumes have returned to normal. Everyone feels like almost more robustly so. And I think the interesting thing now will be, is the mix and is the sort of proportion of procedures that's being done, between the various different types of stress tests, between the different types of coronary imaging and so forth, is it the same, or have people said, hey, let's just take another look at how we're doing our imaging and maybe make a shift? We were doing a lot of coronary calcium scores. Let's stop that. Let's really focus all of our resources and energy somewhere else. Like, will the proportion of images and types of procedures be the same in our follow-up study? That'll be something that will be very interesting, I think, to look at.
Yep, congratulations again on this just Herculean work of 108 countries and 909 sites. I want to invite Dr. Einstein if there's any other comments to add, and then Dr. Shah to follow on really how do we place these contexts in a global context.
Thanks. It's great to join you for this Twitter podcast. I would start off by underscoring your introduction of Cole, who was really a superstar resident at Columbia, and we're delighted that he's at Cornell as a cardiology fellow now. He's been doing such tremendous research with the INCAPS group, both with the INCAPS 1 study and INCAPS COVID, the first study, and currently on the INCAPS COVID-2 study. So just really a shout out for this stellar young investigator who's a future leader of cardiovascular imaging. I would echo a lot of the sentiments here. I think we saw variability within the United States in terms of the drop off of testing. We saw differences between procedures, and the big question is, how will the recovery be? And that's really the focus of INCAP's COVID-2. There's an opportunity still for people to participate in INCAP's COVID-2 if you haven't. We have people from over 100 countries who are participating already, but we'd love for you to join us. We were specifically looking for additional representation. If you're familiar with the bit.ly websites, it's bit.ly/INCAPS2. That's the site to participate. It should only take about 10 minutes of your time to complete that survey, and we'd love for your participation. The final date for contributing data is a week from today, July 15th. And that'll really help us better understand. We've all heard anecdotal reports. This is something which Dr. Salerno, who I think is having the technical difficulties, pointed out earlier in his institution. They're seeing a robust recovery in terms of the number of procedures being performed. But is that the case across the globe? Is that the case for patients with known or suspected cardiac disease across the globe? People in India, people in Brazil, where the pandemic has really been surging in recent months. Is that the case that those patients are getting necessary cardiovascular testing? So I think we're very interested in finding out what's going on in the United States in terms of recovery of testing in general, regional variations in the recovery of testing, and differences between procedures, as Cole pointed out. But we're interested in finding differences between the United States and worldwide, and seeing if there are hotspots in the world for which there might be interventions needed, because individuals in some countries simply, even in 2021, have not been getting this necessary cardiovascular testing, and those should be places where we need to take a careful look at the long-term implications on cardiovascular outcomes, not simply the use of testing. So I think it's a moving field, really trying to take the pulse of what's going on across the globe, and we found out what's happening in 2020, and looking forward, perhaps with your help, our listeners, what's going on in 2021. You can email me, andrew.einstein@columbia.edu, or simply go to bit.ly/INCAPS2 to participate in the second survey in the next week.
Right. Thank you, Dr. Einstein. Yes.
Yeah, I have a quick question for Dr. Einstein and Dr. Shaw. How do you think this work is going to help us prepare for the next pandemic? I mean, because this is very valuable work, but how will you put that in context in your current and future plans?
I think that's a great question. I think one of the things which we're focusing on in a forthcoming Latin American paper led by Rodrigo Cerci is the relationship between decreased mobility from cell phone records and decreased use of cardiovascular testing. So I think there's signals which we can look at in populations and identify them as potential markers of places where patients are not getting the right testing, or maybe that there's a disconnect between the onset of a pandemic and the use of cardiovascular testing. I think certainly places with higher than average decrease in cardiovascular testing, which was true in much of low and lower middle income countries, they really need to take a careful look at cardiovascular outcomes and make sure that those testing is made up for in patients. So I think there's a lot of data here. Our focus on this podcast our USA paper, but really we've got a series of papers across the globe. Dr. Williams is leading a European paper, which we hope will get published shortly. We have a Latin American paper in press. We have an Australian paper in press led by Nathan Better and his team. We have an Asian paper in press in JACC journals. In fact, in the new JACC Asia journal that's led by Takashi Kudo in Japan. We're working on an African paper. Maurizio Dandi is leading an Italian paper where we have many sites represented. And as you'll recall, Italy was one of the hardest hit places by COVID in the beginning of the pandemic. So really, there's a lot to learn about how the pandemic has affected cardiovascular testing worldwide, and we need to make sure that patients aren't missing out on these potentially life-saving procedures.
Yeah, all right, Dr. Shaw. I want to make sure Dr. Shaw,
Sure,
Dr.
sure. And
Williams.
then I want to do a segue. I'll do a short segue, and I'll just frame it from New York. And I apologize; it's going to be a New York-centric statement. There's nearly 1,000 patients died every day during the peak of the pandemic here in New York. Generally, it's about 450 a month. So we lost patients. In our response by just shutting everything down, failed to acknowledge. And of course, we were all going a little bit in the dark, a lot in the dark with COVID. But it was not, to Juan's statement, is we have to learn from this. We have to learn that we have to, in the setting of other types of infectious disease or other types of epidemics or pandemics, we have to learn to take care of all of our patients. We can't just shut down people. Patients' diseases don't just shut down. So we have to just move beyond this and come to some form of an idea of how to actually effectively take care of our patients who require testing. And it's been developed and used worldwide for a reason. And I wonder if Michelle could just, if Dr. Williams could comment on her perspective, because she's been a real active investigator in this group, and just, take it from a European perspective, a UK perspective, Scottish perspective, Michelle. And what
Leslie,
yeah.
yeah, I think it's really important that it is so different around the world. And some of that is because of when the pandemic's hitting in various places early on, Italy, New York, and some of that's about political factors or vaccination factors. There's so many factors affect these things. But the thing that we need to really always remember is at the end of the day, these are patients who are missing out on tests. And wherever they are in the world, these patients may not present again until they have their heart attack. And that's an important missed opportunity for so many people around the world. And how we recover now is really important. Are we going to do the same as we did before? Are we going to do better than we did before? And it's a real opportunity that we can take to actually address some of the inequalities in our health services around the world, so that we can better look after our patients who have heart disease or might have heart disease. And as Andrew was saying, the INCAPS COVID-2 survey is such an important survey, because how are things changing now? Some places are in the middle of new waves of the pandemic. As we chatted about a few times, new variants are coming along, things are changing. And we need to be prepared for the next time these things come along. So there's an awful lot we can learn from these, the INCAPS 1 and the INCAPS 2 surveys. And this paper showed that even within the US, there were variations in practices throughout the US, let alone around the world. So those are my brief comments. Thank you, Leslie.
Yeah, for Dr. Sean Williams, and you point out, and the paper points out, potential for millions of misdiagnoses. How does this data then impact what's coming or what's currently here with this Delta variant, especially with regard to staff and patient safety in imaging?
I think it points to the need for higher vaccination rates. I think we all should be very convinced. I know we had our previous focus on a case series of myocarditis, but it's still there's demonstrable evidence even with the Delta variant. So the recent Israel study showing 60%, if I recall, protection, something around there, 64%, but still even for hospitalization, it's a very, very high rate, and we need to get people vaccinated. And, I think the healthcare leadership, all of us need to encourage both our colleagues, because we still have colleagues who aren't vaccinated and don't want to be, is we need to encourage higher rates of vaccination so that we can get back to taking care of coronary disease in this country. Certainly we're seeing an onslaught, but some sites, have lost patients. The extent to which those patients had sudden cardiac death or ACS, missed ACS, is unknown, but certainly is a strong concern. And we know that we have effective means for early diagnosis. And of course, it's frustrating to all of us, in the cardiovascular imaging fields, is to see these great tests not being utilized as effectively as possible. And, I think obviously there was a lot of consideration about prevention. We have throughout the pandemic lost lives in terms of sonographers and others who were exposed to COVID and ended up passing away. And, we all have a place in our heart for all of them, and thank them for all of their dedication to caring for patients. But we've got to do better. We've got to create a healthcare system that, as Dr. Williams said, that can actually diagnose as well as take care of the other types of conditions like COVID. And of course, that's a daunting task, but everybody that I know is listening is incredibly talented, incredibly smart. And I think we can come up with solutions where we can do both without sacrificing cardiovascular care and leaving patients presenting either having sudden cardiac death or presenting with much more advanced disease. We actually, Dr. Einstein and I actually have a project that's funded by the NIH where we're going to be looking at disease progression in COVID patients. And hopefully we won't find any, but I'm sadly think that we might find very active progression as a course of both the stress that's been involved in the pandemic as well as exposures. So Michelle, should you have the final?
Yep.
I think you should have
last
the final word.
Yes, last word to Dr. Williams.
Thanks. I think it's just about looking to the future and working out what we can do to treat our patients with cardiovascular disease or possible cardiovascular disease better, and getting prepared for the next pandemic. So learning about what's happened so far, and seeing how we can improve things for the future.
Well said.
Well said. Well, I want to thank Dr. Hirschfeld, Einstein, Williams, and Shaw for this, participating in this discussion, and also to the INCAPS group. Congratulations on this important new paper, and as Dr. Einstein mentioned, to encourage INCAPS 2 participation as he has outlined. Also thank Dr. Lopez-Matei for co-moderating discussion, and for JACC Journals and the American College of Cardiology for hosting this discussion today. With that, we'll close and have a wonderful day and lessons learned from this hour. Thank you all.
Thank you all. Till next time.